Thank you and welcome everybody to today's meeting of the Health and Social Care Committee at the London Borough of Hillingdon. This meeting is being broadcast on the Council's YouTube channel, Hillingdon London. The purpose of this committee is to monitor services provided by health partners and adult social care and review their performance. We also undertake in-depth reviews and witness sessions on specific topics and submit our findings to the decision-making cabinet. My name is Councillor Nick Denys and I'm chair of the committee. Before we start, I have some important housekeeping for everyone present. Please ensure any mobile phones around you are on silent. We are not expecting a fire drill, so if the fire alarm does go off, please follow officers out of the building. Please keep your microphones muted when you aren't speaking, then unmute and speak, because the speakers are working, and we had this on Thursday. If two microphones are on, it can create a horrible noise. So, yeah, it'd be good to remember to do that. As chair, I will call on those to speak during the meeting. It's worth noting that some of the councillors on this committee may be using devices to access agendas and papers for the meeting. So I'm going to start with item 1, which is apologies for absence. Nikki, do we have any apologies?
Chair, we've had apologies from Councillor Punja and Councillor Nelson West is here as her substitute.
Welcome, Councillor Nelson West. Thank you. Do we have any declarations of interest before the meeting? No? Fantastic. Minutes of the meeting on the 19th of June. Are we happy to approve those? Yeah, fantastic, thank you. Item 4, exclusion of press and public. Everything's public, isn't it, tonight? Fantastic. And so we go on to item 5, which is our single meeting review, GP coverage in Hillingdon. Now, this is an issue which the committee have been interested in a number of times, because it's something that our residents are very interested in, which is essentially how our GPs doing in terms of coverage and access, and also we hear a lot about other ways of getting medical health care, such as pharmaceuticals and going directly to nurses and all this sort of stuff, which it seems like a good idea in many ways, but how is it working altogether? So we have is it 3 or 4 potential speakers tonight? I'm looking at you, Carlene. Are you going to speak? You're just going to listen? Okay, fair enough. So we have 3 speakers, and then the committee will ask questions. So first off, I'm going to ask Eddie Jan from the CEO of the Hillingdon GP Confederation, just to give us some headlines about what is happening with GP coverage and health coverage in Hillingdon.
Thank you, Chair. Yes, my name's Edmund Jan. I'm the CEO of the Confederation Hillingdon. We're an organisation that represents and works with 42 of the GP practices in Hillingdon, and those practices are also formed into 6 networks. Those networks have appoint clinical directors to clinically lead groups of about 7 or 8 of the practices each, and all of those clinical directors are on the board of the Confederation, so we try and bring together a common voice for general practices as providers of services to the local residents. So that's a bit of just about me to start with. The frame of reference for the meeting picked up on several themes that you asked us to answer and look at, covering various aspects of GP coverage in Hillingdon. I think the first thing to point out is that GPs are contracted nationally with a national GMS or APMS contract. They're also contracted nationally for additional services in something called the DES, which was brought in 6 years ago. They're also contracted at a North West London level from our ICB, our Integrated Care Board. And so every practice in Hillingdon performs to those contracts. And increasingly over the years, probably over the last couple of decades, there's been an increase in consistency through those forms of contracts into what is actually delivered. The individual practices are still independent, so some of how they deliver the services are different, but there is a lot of scrutiny into what they provide, and it is reasonably standardised. In Hillingdon, the practices themselves still provide the majority of what's required, but there is an increasing element where they can pool together in their local networks to provide some local services. Some of the groups of practices will run diabetic clinics or other such clinics. And then the Confederation provides services that are not provided by either the practices or the PCNs, and in effect provide some additional services. We would run things on the basis of trying to provide things at scale. So we provide an integrated care home service, for instance. So there's well over 40 care homes in Hillingdon, but the residents of the homes require quite a lot of specialist attention. So on behalf of the GPs, we partner with CNWL to provide a borough-wide care home service. There are also some specialist services which are really difficult for GPs individually to run. They may not have the skills in their partnership or with their nurses, and so things like women's health clinics, weight loss, healthy lifestyle clinics, warfarin monitoring, some specialist work that's come out of the hospital. So we do run that because there just isn't the skills within individual practices. And then finally we do some what I'd call almost like top-up work. So if the capacity within a practice to do spirometry or ECG tests or hypertension monitoring dips, or because of their particular resources they don't have the capacity to provide all of that, they can refer patients into our clinics to make sure they try and get 100% of their requirements of their patients covered. So increasingly there's a collaborative nature across the practices, the networks and the Confederation to try and maximise the services available to the patients. I think another thing that's been changing over the last probably or it's been accelerating over the last 3 or 4 years is that general practices used to be provided with a lot of support, almost like the services and support functions from the NHS that used to be provided by the local CCG, and they got moved to the ICB. So things like workforce and training, technology and digital, estates, those sorts of support to general practice. Those support functions have been diminished over recent years. And it's fair to say that's a planned move in some ways by the NHS to move more of that responsibility to the providers themselves. And so GPs in the individual practices are quite small organisations. So they will have a practice manager and they will have administrators and receptionists, but they won't have a digital manager, an IT manager, an HR manager, etc. And so that's where organisations like the Confederation comes in, where essentially the GPs pool the resources and say, we need this support from you because it's no longer coming from the NHS as much. And indeed contracting works a lot like that now as well. So the ICB is a strategic commissioner. It says we need the practices in Hillingdon in these primary care networks to meet these targets. We will measure you on those targets, but how that is dealt with and delivered locally is dealt with through local contracting. So within each of our networks we organise with the network and with the practices who does what, again to make sure that we're optimising the outcomes so that what can't get done in one practice can still be achieved for the patients from that collective group of practices. So actually there's a lot of contracting done locally now to make sure we're meeting the strategic contracts and the strategic objectives, but we're doing that by organising ourselves locally. So this gives you a background in terms of how general practice is trying to organise in Hillingdon, and in some ways, I guess, modernise. And with that comes the changes in delivery itself. We have organised access plans with all the practices and the network. So there's 6 networks, there are 6 access plans for the coming year. The ICB has said what it wants to see in terms of improvement to access, in terms of anything from how quickly the phones are answered, 90% of calls in 10 minutes, how many patients are using the NHS app, what are we doing in terms of patient engagement to get feedback from local residents. Also, how are we starting to pull together named teams for people with complex conditions that need now to have a named team that they can access directly. So almost like trying to get us back to that idea of not quite my doctor. My doctor is Dr. Seymour, but my team is Dr. Seymour and nurse and pharmacist, and so I can go to any of those 3 because I'm a complex diabetic, etc., etc. And so there is this access plan that is now submitted annually, and we've put that in. It deals with the technology, but like I say, it's also dealing with very much trying to move for complex patients to a more personalised view at the same time as dealing with that sort of same-day urgent type demand. And with that, there's also an increase in engagement with a wider partnership. There's quite a few questions within what you're asking about pharmacy involvement. It's not particularly a specialist area of my own, but hopefully we've provided a lot of supporting information around that. And it is true to say that Pharmacy First is an important initiative. There are 7 key conditions that can get referred or self-referred as well to pharmacists, but there are other conditions that patients are getting added into that, so patients can access their pharmacy. And that's part of a picture of trying to broaden the options for patients, because even after all we're doing, there is significant pressure on GP practices with increasing demand. They have increased their number of appointments, and yet the patient experience, as reflected by surveys, is still not where we'd want it to be. So there's a picture of quite a lot of initiatives getting taken, quite a lot of change and collective action, quite a lot of partnering going on. Is it keeping pace with the demand? Is it getting on top of it and improving things? To be honest, I would agree that the jury's out, but I think there's a lot of effort going in, a lot more application going in, and I think it's also something where there's a lot more listening going on, and it's not being done in isolation in individual practices. So one of the things with the access plans that were put in was there was a major engagement exercise, and we got 5% of the registered population in Hillingdon feeding back into that exercise. So it's quite a major initiative and engagement exercise to try and make sure the plans were starting to address some of the access challenges. So I think I sound in my own ears as if I've talked for quite a long time now. I hope that summarises a fair bit but I'm happy to hand over to others.
Thank you. It's partly these microphones as well, making you feel like that. But no, that was all interesting, useful information. I'm sure we're going to have quite a lot of questions on that stuff. So Sean Bidwell, is it Bidwell? Yep. Yeah. From the North West London ICB Integrated Care Board. So could you just explain for everyone here what role the ICB has in this, and then talk about maybe some of those standards that you are setting, and I think we're all quite interested in how those standards are sort of policed, enforced, and all that sort of stuff as well, if that's okay.
Yeah, thanks. So I suppose the ICB has, well, it doesn't have two parts to it, but so I'm part of the local borough team, so I'm here based actually in this building, and we work really closely as part of the partners of HHCP, so Hillingdon Health and Care Partnership. So centrally the ICB, I think, as Edmund said, it's moving towards that strategic commissioner type view. They've got their central functions there that look after primary care, local care, integrated pathways, so that your acute side and your community care. So they deal with all the contracting pieces and link in with the local partners, so for CNWL for mental health, community health, and Hillingdon Hospital for the acute. And actually from the primary care side, they'll be linking in with PCNs, Confederation, and GP practices. So they go through all the managing and the monitoring of make sure they're sort of in line with their targets and review everything that's going on, and run the contractual side of things. Locally from the borough team, we're just fully integrated and involved as part of the place-wide system. And so we're working with all the partners, as I've just said, to work on kind of the local delivery of that. So pretty much like everything everyone has gone through, we all do together, but all around the table. So we're always looking at how we can change things, improve things, make things better, and work through things together. So probably not much more to add than the detail there. The only other thing is I suppose, so we say the change that's coming up with the way the ICBs are changing. So I mean, the one thing we know, ICBs are going to continue. The other thing is ICBs are going to move towards that strategic commissioner focus. So very much what the central areas are doing now will remain. What we don't know as such is what happens out locally, but the idea is those functions will move to, I mean, there's different terminology they use. I wrote it down a minute ago. The neighbourhood health organisation, or that sort of thing, where it's led by one of the place partners, potentially, and I say potentially because nothing is finalised, we don't quite know yet, but the idea is it would move back over to the place partnership to actually support and take that forward, and then the ICB in their part, you would report back to them and work with what they're doing. So you probably wouldn't have maybe a designated person as ICB employed, but you would have the responsibility, and the roles and stuff would sit with that place partnership lead doing what we're doing at the moment.
So before we move on to Lisa from Hillingdon Health Watch, I think it'd be really useful for you, and maybe if it's Eddie, then Eddie as well, to talk about what this sort of place-based partnership means, because it's one of those NHS language things that gets mentioned a lot, and I have a good understanding because I sit in a lot of meetings where people speak NHS language, but I think for most other people it'd be useful to mean, what are you talking about when you talk about place-based partnerships, this neighbourhood health service idea where a GP, a lead clinician will sort of organise multidisciplinary teams to sort of deliver primary care networks. Again, I can't help but slip back into NHS language, but I suppose really what does that mean in terms of delivering better outcome for local patients?
I will try. To try and explain it can be quite difficult, but maybe if I touch on a few things. So you've got, I mean, we're doing a lot of work at the moment that you'll hear different terminology. So I can't even remember what the terminology is, but there are different names of what these functions are going to be called. But two of the key things that I suppose we're doing, let's talk about integrated neighbourhood teams. So it's kind of what does that mean and the benefits of it. Actually, it should bring the care closer to the patient or resident and bringing everything together, so you don't have different multiple hands off with, it could be the same organisation but different teams, bringing everyone together. So for example, we've got integrated neighbourhood teams, it will bring together the primary care networks, the work that Eddie's talked about. It brings in a lot of the core services, so you've got your community nursing teams, bringing together some of the MSK, physiotherapy, community mental health teams. It's bringing in adult social care, third sector organisations, and bringing in where necessary or where needed some acute services as well. So it could bring out some commute services that are currently delivered in the hospital and could be more localised done. I mean, an example of that has worked really well is the Children's Integrated Paediatric Clinics. I think they've been running for about 3 to 4 years, probably slightly longer, and that's where the team moved out of the hospital into the community, and children can be seen in the community rather than going to hospital. So it's in your local care setting, and under these organisations or areas, because hopefully what we're looking to do is have integrated neighbourhood hubs, which is where you can have all these teams together. A patient can just come in and you don't need to go, I'm seeing nurse A or B or doctor A or B. You go in and you'll be seen, and you get all your needs met by whoever is there to meet those, whether it be healthcare, social care, voluntary sector support and stuff like that. So I think that's one of the benefits that should come from it, and that is the way we're moving, trying to move forward. The other part, in a way, that we're doing locally is we're looking at how we can bringing those teams together actually is we can improve or reduce, I say productivity is probably a better way. I don't want to say inefficiency because it's not saying it's inefficiency, but you could have one team that response service. You could have your tissue viability service or your district nursing service. You could be seen by a nurse on 3 different days in relation to 3 different things. And by bringing those services together, you meet all the needs that you need to. So you're not just doing the rapid response element, you might do the actual district nurse piece. And so you get a better experience for the patient as well, the patient stroke resident. So they're looked after in that way. And reducing down those unnecessary but improved flow of contact points, you'll be able to see more patients from within the same resource and over a bigger piece. And actually having teams local, you'll get to know your residents and actually know them a bit better rather than just being someone that you've probably never seen before, because a lot of those patients, when they're on there, they can be on there for a long time as well.
And are those based out of the 3 hubs? The one we went to the one in the north, didn't we, in Ruislip Manor? So is the idea there's going to be 3, one obviously in the north in Ruislip Manor that we all visited as a committee, one in sort of central area and one in the south area of Hillingdon, yeah?
Yes.
Okay, brilliant. Okay, well, I'll stop there because lots of other questions want to be asked, but I'll finish off with our witnesses from Lisa Taylor from Health Watch Hillingdon, and we're extremely lucky because you've actually just finished a report, haven't you, into GP access experience of the Hillingdon community, which I luckily got an exclusive early copy of, one of the privileges of being chair of this committee, but it got signed off very recently, so you can talk about it at this meeting. So I think that's really useful for you to talk to us about what you found in the research there.
Thank you, Chair. Yes, so as a Health Watch, I would think I'm right in saying, and probably this is true of all Health Watchers, getting a GP appointment is probably the most common thing people contact us about. So, and as Eddie's already sort of alluded to in the sense that we know that there's been an increase in the number of appointments offered in Hillingdon, but actually patient satisfaction doesn't quite align with that. So we were really interested to find out, okay, what are the sort of ongoing issues. So throughout 2024, we carried out some research with the Hillingdon community just to understand their experiences around access and using GP services. So we started with a survey which we ended up putting on hold because of the North West London ICB's engagement around same-day access. And instead we focused on doing some more targeted engagement with certain groups in the community. So we spoke to carers, traveller community, people experiencing homelessness, adolescents and young adults in the care system, and asylum seekers and refugees. So we've got quite a range of views and experiences. In terms of key findings, 62% of respondents said they were satisfied actually with the outcome of contacting their GP. Where there was significant dissatisfaction, however, it was with aspects such as booking appointments, online systems and continuity of care, and this was particularly prevalent within the working age group, who felt that booking systems and phone systems just didn't quite meet their needs. So in terms of the key themes, so booking systems and availability, rigid 8 a.m. booking windows were mentioned, and this is not just on the phone now but also applies to the patches system. Long phone queues, which we know that there's been some work done to try and reduce phone waiting times across the borough. Delays in securing appointments that met people's needs and lifestyle, obviously. Where some GPs offer callbacks to try and avoid people staying on, waiting on the phone for appointments. A lot of people told us that they were often missed and then they had to start the process again. So there's something about that system that it's a great idea, but I don't think it's quite fully meeting residents' needs at the moment. With regard to technology and online access, limited access hours for the patches system was raised quite consistently, with technical issues creating the need to then revert to phone contact. So people obviously not being able to do what they needed to do online and then having to phone the surgery anyway. There's confusion at the moment because there's a lot of, we have the NHS app, but there's also there's multiple digital platforms that people have to navigate at the moment. And that can cause a lot of confusion. And for a lot of people, their ability to use digital systems with confidence or even have access to devices can be an issue. Form filling, particularly with the online systems, is a barrier, particularly for young people and those with poor literacy. And some patients still have concerns about data security. And what's happening with the information that they put on the system. Continuity of care was another key theme. Lots of people talked about inconsistent follow-ups, meaning patients needed to contact the GP practice multiple times to get, test results and things like that. People felt the reliance on locum doctors meant that they were having to repeat their stories. And that sort of had an impact on confidence and trust in the practice. And because of that, a lack of familiarity with patient history really does impact patient confidence quite significantly. And obviously these issues were particularly prevalent for people with complex or chronic needs. There are some barriers still for seldom heard groups, so language barriers, and this is exacerbated by limited appointment times, particularly where English is not a first language, and people don't feel able to fully express themselves or make the most out of their GP appointment. And we did sort of hear about there being a lack of interpreter support in those cases. People with hearing impairments also told us that they felt that their needs weren't necessarily supported through the phone systems, and with difficulty navigating the online systems, they didn't find that particularly helpful either. And particularly people who are experiencing homelessness or asylum seekers who have had sort of specialist support whilst being in accommodation, they find it quite difficult to navigate care after leaving those places. In terms of communication, both Eddie and Sean have talked about the sort of team around the patients rather than just the GP. There's a lack of awareness of patients at the moment around the roles within the practice and what they offer, and clinical competency, and some sort of lack of confidence around, are they being referred to the right practitioner. There are concerns, particularly people have a lot of concern regarding providing personal information to receptionists who, as we understand, are there to provide a triage service, but a lot of patients don't understand that, and that's the reason for it. So we've sort of called for some better communication around that. And people told us about the different contact methods. So there can be a combination of texts, results being given through the NHS app, that sort of, patients find that quite confusing actually in terms of keeping a track of their, you know, what they need to do next, or, you know, what's happening. So the other thing to bear in mind as well, particularly with people who, as I said, maybe English is not their first language, is the reliance then on having to use a third party to get access to a GP, and that's obviously an issue around confidentiality for lots of people. So that's quite a big issue that we're hearing about at the moment. That's it from me. I'll leave it there for now. Obviously, we've made some recommendations for improvement in our report, and as Pharmacy First has come up, we've also done a review of patient experience Pharmacy First as well, which we're currently writing a report for at the moment. So that should provide a bit more insight around how well that's working, and maybe some improvements that are needed there as well. So,
thank you. I'm sure some of those issues are going to come up in questioning, and I mean we had a single meeting review on pharmacy coverage as well, which obviously the things are linked in terms of primary care and how it's done. I have one question before I'll open it up to other committee members, and that's about capacity, because obviously I mean, do we have enough GPs in Hillingdon? Are we worried that quite a few of our GPs are potentially coming to retirement age? You know, at the moment, is capacity an issue? It feels like it is, in terms of people not getting appointments when they want and all this sort of stuff. So I just wondered, you know, are we okay in terms of the amount of GPs in Hillingdon and coming through in Hillingdon?
If I start on the answer with that, we have actually recently had an uptick of the number of GPs working in Hillingdon, and it's a complex picture. But there has been a bit of an uptick. It's come from the fact that we've proactively sought to get more training practices in Hillingdon. That means we're training more students, and that provides what we call, unfortunately, a pipeline of newly qualified GPs. And the first place a GP often accepts a job is the place where they trained as a student. So it does actually bring us more young, newly qualified GPs into Hillingdon. We've also tried to make use of things called fellowships, and also supported them with mentorships, so that could provide additional interest and further training and support, again particularly for newly qualified GPs, but potentially also those returning to work. And then finally, there is an expansion of an additional roles scheme. It's called the R's staff, and these are the additional, this is the means by which general practice has introduced additional skills into general practice for the last 5 years. And one of the things that was identified last year was, at the same time as there being more demand for GPs, there were unemployed GPs. And it's like, what's going on? So when the new government came in, one of the first actions was to include GPs in this additional role scheme, and put some more money in. So we've appointed a couple of more GPs in Hillingdon last year already, just in the last 6 months, and are busily trying to recruit 3 or 4 more right now. So the picture, after several years of slow decline, I have to admit, has picked up in the last 12 months. I think, having said all of that, there are a couple of words of caution. One is that I think it's pointed out somewhere that 25% of the GPs in Hillingdon are probably there or close to retirement age. So that's a quarter of the workforce, so that's a high risk. And secondly, the demand's going up, and also some of the GPs coming in, they tend to be more portfolio GPs, mixing general practice with other, either a lifestyle choice not to work full-time or a mixed portfolio of work, so they may work half-time as a general practitioner and half-time doing something else. So the numbers are starting to improve after several years of decline, but it's probably flattening, I would say, and remains to be seen how it progresses. But we have made good inroads recently with that.
Thank you. Councillor Chandel.
Lovely, thank you, Chair. I'm not sure who this question is going to go out to. I'm interested in knowing that we've got 42 surgeries that are into 6 primary care networks and 2 aren't. So as a patient, what is the advantage for me, for my surgery, to be in a PCN? Because I was looking, and this is feedback from friends and family, a certain practice gives a better service, they've said, and get better appointments. So I'm looking along here and I'm thinking, that surgery I want to move to is under the same PCN as my existing surgery. So as a patient, what's the advantage of my surgery being in a PCN?
I have a stab. I suppose, I mean, the first, your practice will provide your appointments and your care and stuff, but by being part of a PCN, they're able to support as well. So, for example, if there wasn't any, you could actually move, the PCN could pick up some of that support as well. So actually, you get your first point with your practice, and you get some PCN support there, but you also get, by being in a PCN, you sign up to the sort of North West London single offer enhanced services and stuff like that, which then provide alternative stuff as well. Additional services on top of what your practice offer and stuff. So that's what, by being a part of a PCN, they're able to deliver that, and a bit more at scale as well, rather than doing it at the individual practice. So you should get a better service overall by being part of that.
Could you give us some examples of some of those additional services that PCN might be able to provide?
Yeah. One of the points are these additional roles. So all PCNs in Hillingdon employ pharmacists now embedded in their practice teams, and most independent practices couldn't do that. But on top of that, there are roles such as social prescribers. So, if a GP indicates during a consultation that the root cause of what's going on here may be a housing problem or a benefits problem, then there's a member of the practice team as a social prescriber, or indeed a loneliness problem and such like. Then the social prescriber can sit with them, not just for 10 minutes, but for half an hour or an hour, and work through that and organise activities or a charity or other function to support that person. They also have physios, podiatrists, dietitians, and they can all be accessed directly from the GP practice and actually be seen by those people in the GP practice. Now, on the one hand, that brings into question, who is this person I'm seeing? They're not my GP, they're a physio. But from dealing with musculoskeletal issues, that physio will know a lot more than their GP, and the GP will defer to that physio to help sort out that patient. So there's a much wider range of skills that are accessible within your general practice if you're a member of a primary care network, as an example.
Sorry, Chair, just to follow on from that then. So would it be fair to say that within your primary care network, and this might be more for Lisa under Hillingdon Health Watch, that if you were to rank the surgeries, some would be ranked higher than others in how efficiently they use the whole network system?
Yes. and in terms of obviously the feedback that we gather, we have that ability to be able to rank satisfaction against individual GP practices. One of the recommendations actually that we've put in our report is to review how well the enhanced access services are being utilised by each practice, and just ensuring that the staff within that practice are aware of how to access it for patients, because I think at the moment there's potentially a bit of inconsistency there. So I hope does that answer your question?
Sorry, through Chair. Yes, it does. I'm going to stop there, Chair, because I've had my 2 questions. But I'm sure it'll open it up for others, because if there is that inconsistency, that's a little bit concerning.
You can always come back later, so... Councillor Martin.
Thank you, Lisa. It may be for all of you, but you mentioned that there's been an increase in available GP appointments in the borough. I'm just curious to know whether they are true one-on-one GP appointments, or are they with nurse practitioner appointments included in that? Because I was talking to my colleagues before the meeting. I've been on medication and been with my GP for 18 months and never seen the GP or spoke one-on-one, and I'm just curious to know whether that's a true GP appointment that people have an availability to, and whether that then links to the dissatisfaction markers which comes on the back of those appointments. And then a small question after that. Thank you.
So, yes, I can say there has been an increase in activity. I mean, I'm not going to say 100% that this represents actual GP piece, because I would have to double check, and I could probably confirm back and let you know. But I did take some of the data. So you get the GP national data set that gets uploaded and stuff. So it's probably not appointments, it's attendance, that sort of activities it's called. And actually it breaks it down from face-to-face, home visit, telephone, unknown, there were a few of those sometimes, video conference. And so what I did was I went back and looked in 22-23, there was around 1.7 million of those, and that grew by 6% in 23-24 and a further 9% in 24-25. So over the last 2 years there's been about a 15% increase. The majority of those, actually the increase has also come from face-to-face, so we can see, so I know sometimes I can't see the doctor or see people. It's around just under 68% of all that activity comes through from face-to-face appointments. I can't sit here and say that is representative of just GPs. The only other thing in addition to that, there are obviously other services that go on. So you get the breakdown between wanting a GP attendance. So if you phone your GP, you might get one within a week or two, and then you can get the ones where you need a GP on the same day. So actually the GP attendance is the normal GP attendance. It's fairly flat, but it's increased. It's not gone down, and they're sitting at around 3,500 of those a day. But the GP same-day attendances, actually over this year as well, have kind of gone from an average daily of around 3,000 to 3,500. So actually, it's your same-day availability has also gone up. And then you've got so some of the things that I know the ICB commissioned with the GPs and stuff, and the Confederation, was additional extended access hubs, so the activity going into the evenings, and then we've got some of the same-day non-urgent care primary care hubs. So we've been having around 225 of those evening appointments per day, which has actually increased quite significantly from about this time a year ago, and the same thing for the same-day urgent care primary hub. So you can see the activity, there is more activity. I can confirm and have a look at the types behind it, but I don't have that on this spreadsheet. So.
And just a couple of years ago, I was listening to, I think it was on the radio, and they were discussing there was a percentage of female patients having access to female doctors or GPs. And I happened to that day need to speak to my own GP, and she, the triage receptionist, who was quite short, as you can imagine, was telling me that there was no male doctors available that day, and it was a male-related query. So I pushed back and quoted this article that I'd heard on the radio about women having access to female doctors, and she just shouted 11 p.m. and put the phone down, or 11 a.m. and put the phone down on me. I'm just curious, is there the same focus on access for male to male doctors as there is for female to female doctors in the healthcare service? Because I'm quite keen on that equality, because sometimes I see when I work at a hospital that there is not the same focus day to day in the privacy that men deserve versus what the privacy women receive in the health service. Thank you.
I don't have anything that supports the data on that, but I would be inclined to agree that there isn't the same focus on men's health and equalities around access for health practitioners for men. The focus, and I think the focus of the health service has generally been on equality of access for women. So I think you've raised, I think it's a really, really good point, actually. I think you've raised a gap in the system there. I wanted to come back to your previous point, actually, as well, whilst I'm here, is that with regards to dissatisfaction, according to our survey and the people that we've spoken to, most of the dissatisfaction comes from not being able to secure a face-to-face appointment, because that is the preferred method. A lot of people are actually happy with a telephone appointment, depending on what it is. But I'm just reading through the report again, is that I think it was about 69% of the people that responded were satisfied because they had secured a face-to-face appointment. So I think that probably answers your question.
Great, thank you. Councillor Nelson.
Thank you, Chair. This is for Eddie. Eddie, in your presentation, you said you've got 6 working access plan. You've got 6 access plan working, and from those 6 access plans you have working, also provided hubs. You've got hubs to work with that. Now, how does individual patients or patients who wants to access their GP to get different elements of the services that have been explained here to us today, and that can be either for dressing or for diabetes or whatever, you said in one area that can be done in a GP service, how does patients able to know where these services are and how they can access this? And I'm going to give you an example on that, because myself personally, I had an appointment to have some tests done and x-rays. Supposed to have gone to my GP. When I checked on them, they said, oh, a practitioner will contact you in regards to that under the NHS list that is provided with all the different things, because truly you cannot follow it. And if me can follow it and I'm not good at IT, what about those people who cannot access it? So how is this relayed to the residents when they're seeking this sort of services? Because through the changes that's happened with the integrated system and the ICB, how is this getting out? Because it's confusing for me. I can't get my head around some of it. What about those people who have no knowledge or idea on this matter?
Yes, I think some of the healthcare is complex, and general practice, although it's small scale, local, is still rather complex. One of the points of what we're trying to do with access is turn it so instead of being complicated for the patients to navigate, we deal with some of that complexity behind the scenes and try and make it simpler for the patient. Now that is the plan going forwards. I accept that. I know when it comes to digital systems, I've written down 5. I think there may be a sixth that I've forgotten. And you go, and it's almost like parking apps, and you've got 3 or 4 on your phone, and you've got the wrong one. And it sometimes feels like that with the NHS system. I actually think we only should have 2 of all of it. So I get the complexity point. So the access plans that I was talking about, over 80% of the contents of those plans are actually what is being done within the practices themselves. It starts right at the front desk, the telephony systems. The point about you can use a modern telephone system now and say you're in a queue, if you'd like we'll call you back later. And you go, oh, that'll save me 10 minutes or 15 minutes waiting, I'll press that button. But then the practice call you back and you're not in because you've popped down to a shop or you're carrying on your domestic life. And so, simple things like configuring the phone system to allow the patient to put a time in when they'd like to be called back sounds truly simple, but it is possible, but it's getting missed. So one of the things that we've got in Hillingdon now are 4 digital transformation managers to support the practices in making sense to the patients of their telephony systems, their digital systems, even their websites, so that it is simplified from the patient perspective. One of the points of the access plan is around the telephony and the digital systems. In terms of the additional appointments that are made available, they're all booked in. The ones that we provide are all booked in from the practice. So, from the perspective of the hub systems that we're trying to develop, appointments at that hub are booked in directly through a contact, through your contact with your practice. So there shouldn't be you need to phone somewhere else. The practice can book their patient into our services or indeed into their PCN services directly at that first contact. So that should be happening where it's our services. Where it's third-party services into some of the community functions, mental health functions, that's not possible, and you do end up sometimes having to make a second effort or a third effort. But that comes back to one of Sean's points about neighbourhood working. Part of the point of neighbourhood working is that you should be able to book somebody in to a community nurse when you're contacting your practice, or if you're talking to the community nurse, they should be able to book you into a GP appointment without you having to make a second attempt to your practice.
So why hasn't that happened? Because that sounds good and ideal. So, or I suppose a sort of more positive way of framing that is, when is that going to happen, or what can be done to make that happen?
Well, I mean, that is the essence of what is now getting called a neighbourhood health service. This is where the NHS and the health systems embarrass themselves, because everybody, you'd say, well, there's one patient record. You should all be able to see what my long-term condition is. Where actually we've got silos of computer systems. We have silos going back decades of commissioning systems, so that your community nurses are commissioned as a community nurse, as a district nurse, your mental health teams as mental health teams, and we do unfortunately work in silos, and your general practice team in your general practice grouping. And when a patient needs to go between those silos, it is going from one computer system to another computer system, from one administrator to another administrator, etc., etc. So where I come back to my initial point, the simplicity of it is that you should be able to work as an integrated team, and that community nurse, mental health practitioner or GP can arrange an appointment with each of the others without the patient needing to lift another finger. But behind the scenes, we've got to get all those administration systems, all those IT systems, all that data governance, etc., sorted out. That's what our jobs as managers is, to focus the care in those neighbourhoods around the patients. But it will be a matter of a couple of years of going on that journey, because there's a lot to be undone of what's accumulated over many years before. I hope that makes sense or helps a little bit.
Yeah, I mean, I was just saying, surely the ICB can help with that. As a sort of Northwest London strategic, maybe it's sort of the ICB in Westminster or wherever the main ICB is based, but it sounds like a sort of bigger strategic piece there.
It's probably even bigger than the ICB actually, because you're talking about all the different organisations as well, because actually as a patient you don't just go to Hillingdon Hospital all the time. You could be on holiday and go up in Lincoln, so you need it a little bit bigger. Locally we are working, as Eddie said, around trying to bring, probably not to one system, because I think that's going to take a while, but actually so the systems can talk and work with each other. And the ICB does pull the information, so they've got WISIC, which is Whole Systems Integrated Care, I think it might stand for, but it's where you bring together, so they've started to do that actually by bringing together those platforms and stuff like that. But we need it, the layer behind, where you can track those patients or have access to track the patients, but then you have to go through all of the sort of data protection, data sharing agreements and stuff. So the ICB has done stuff. As a system, we've done stuff. To get it perfect is a bit bigger, but it's those next steps that we're taking to try and get them to talk and bring together.
No, I just wanted to come back. I mean, we're talking with sort of, Sean and I will drift into management speak at times, so apologies for that. But the partnership between the likes of the GPs and the Confederation, CNWL, the local hospital, in moving towards this neighbourhood health system, Hillingdon actually is the most advanced in Northwest London and is one of the most advanced in the countries. So we are quite ambitious and are quite advanced in the conversations and some of the actions required to get there. It is a big job, but it is something that people in Hillingdon are championing and pushing really hard. So some of the announcements in the NHS 10-year plan, we want to be in the first wave of developing that neighbourhood system. So we don't want to be in wave 5 in 2029. We actually want to be 2026 delivering that sort of a system. And we're in a decent, I mean, it's not totally in our gift, but we're in a decent position to progress with that. Thank you.
Councillor Nelson, do you have another question?
I do. I have more than one, but I'll stick with the two for now. Under the paperwork that's given to us on page 14, you've got a PCN are a key aspect of the NHS long-term plan, and it gives a map below showing the PCN in Hillingdon that's aligned to GPs. Can you explain how this PCN allocation is done? And integrated into that, I will also push again, under the PCN and the GPs, there is still no GP service in Hammondsworth, Longford and Simpson. When Mr. Spencer was here, he was looking at securing premises or looking at areas to secure a GP service within this area. Can you please tell me whether this is continuing, what it is that you're doing, and how are those residents within that area that has no GP service is able to access a GP service?
I will answer a couple of those. I mean, I don't know about the plans around the securing land, property and stuff. I know Sue and Keith, who couldn't be here today, are probably a lot closer to a lot of these areas and stuff. So I can ask for them to give us some of the updates on there. Some of the things that we do have in place to help support. So I know we've talked about the North West London single offer, and part of the PCN, I think it's what's the HH Collaborative, it's one of the PCNs there. So we've got the HESA practice, and part of the contract there is actually is for them to take on patients within the area, within there. So there are some practices that are not, I know they're not in the area, but are there to actually take on some of the patients and support from there. Them being part of the PCN as well can supply some and support with some of those additional single offer to those residents. We actually have been looking, so I know we talked about pharmacies and stuff like that, and I think Sue was doing some work to actually see, and there's a couple of pharmacies that fall within that area, and it's looking to see whether she's already reached out to some of the neighbourhood teams, so the areas that cover those areas, to see if we can reach out to see if we can start providing some of those care services that they provide as well from that pharmacy as well. So I know there is stuff being done to try and help support patients and residents there, but I don't have a lot of the details on building and land allocations and stuff. So I will probably say we can ask Sue or Keith to give us some updates there to provide back to you.
Yeah, if a written update could be provided by Sue or Keith to Nikki on that she can share that with the committee, so that would be much appreciated. Thank you.
Nikki, are you able to phrase me the question? Yeah, perfect.
Yeah, it's a matter that's come up before in terms of what's going on down there, so thank you. Councillor Hagger.
Thank you, Chair. Really good stuff. And going forward, I remember sitting here probably about 8 years ago, and the hospitals weren't talking to each other, and they are now, and they're using the same database. So definitely we're getting somewhere going forward on a positive note. My concern actually is what we were picking up earlier on, and from Councillor Nelson, is, and we've seen this with our residents as well, is where they're coming in, obviously, they're going to their GP. Here we're looking at a great format. We've got the PCM, we've got different areas, they don't talk to each other, as we know, they're all on different systems. How can our patients be assured that they're not going to get lost in the system, that we're not going to end up giving extra time out, because obviously they're waiting for another service that's been in the system, and how are we communicating that back to the GPs as well? So when they go back to their GP, that their GP knows what they've accessed within those hubs and that system. And I think, Eddie, you spoke a little bit about that being all under one GP, and it's obviously in one area. So you did speak a bit about that, but then we also spoke about the cross-sector of different areas. And I think my concern is that patients could end up waiting longer, maybe even, I've had some residents that have gone in, have expected appointments, with physio, and it hasn't been done, so the GP actually didn't do it, or the hub that they went to see, because it wasn't the GP, it was actually a hub, didn't do it, and so that's ended up having a longer time wait because it hasn't been done. So I know you probably haven't got the complete answer, but I think it's just how are we going to stop the gap, really? How are we going to plug that gap from not being able to access all the systems? Thank you.
I think in many ways the last 5 years have seen a lot more cooperation across these groups of general practices and these networks, and their teams of staff are collaborating a lot more. If you just pick up on physio services, they are a classic piece where there are now first contact physios employed in general practice, working really closely with the general practice team and the GPs in particular. But there is also another tier of physio service working in CNWL, the musculoskeletal services, and then there is a more specialist physio team working in the hospital. And quite frankly, the joining up between those, it sounds like a derogatory term, but those silos is still not very good. And I think that, if you take that physio example, you can fill out a form still, and it looks almost the same. Some of the questions are the same, and you've submitted it once into the community team, and you've got to do it again to the hospital. So those are the very types of system that the neighbourhood working has got to break down. And one of the moves in Hillingdon would be to have an integrated physio service, so that from first contact, which is normally still in a GP practice, that first assessment, you can actually move across the physios, and those physio teams ultimately being co-located in the 3 hubs, so that the from first contact right the way through to specialist are actually working alongside one another. That's the plan, and it probably is a 3 to 5 year plan, because there's also estate comes into it and the like, but it is very much the picture of what we're trying to do, and to a certain extent it's developed across and between the practices. We've got to get it working between general practice, the community, the mental health and the acute, and I'm almost replaying to you one of the previous answers, but using the example that you've raised.
I mean, that's really good. I think we've just got to be really careful of our patients not, missing and having that time delay. The other question I just had was on page 13. It might be a bit of a silly question, but on page 13, again, we brought it up a little bit before, but what I wondered was, why have the 2 GP practices made the decision not to be allocated to a PCN? And I just wanted to ask that question, because in some ways I can see, the really old system where you go to the GP's got everything about you, knows everything about you, knows all the inside, you go somewhere else, come back, GP knows, right? So that's it, the GP knows, got everything written down, so you're not really getting lost. But is that why these 2 practices, I mean, it probably isn't, but why have these 2 practices decided not to? If the hub's so good and the PCNs are good, why have they decided not to?
I don't know, is the honest. I wouldn't want to speculate, or the practice decides to stay separate. I do know that our central primary care team, which is in the ICB, are working with the practice to ensure that their patients and residents, and your residents and patients there, aren't missing out on service or having their services met. So I know work is ongoing with them to ensure that is continued, but I can't give you a reason why. I mean,
is it worth pointing out it's the same GP for the 2 practices?
Yeah, sorry, it's the same GP for those 2 practices. Yeah. So that's why it's 2 practices. Yeah, so it's one. Yeah.
Thank you, Councillor Bells.
Thank you, Chair. And I think the practice I use is the one that it's not part of the PCN. I can't see it in the list here anyway. But I do get all the services, a very good service from them, so I do feel, I don't feel I'm losing out by not being in it, to be honest with you. They don't leave me alone. Well, my question is on planning. How do you plan ahead? I'll give you an example. When St Andrew's Park was built many years ago, well, not many years ago, but a few years ago, part of the planning was a GP surgery on the site, and I know it was under the NHS under previous management, so to speak, and it quietly got dropped for various reasons. So that's meant that all the people on the St Andrew's site have to use Uxbridge services now, and that's put extra pressure on the Uxbridge. And I'm just looking at the numbers of patients, and the Uxbridge surgeries by proportion seem to have more patients than anybody else. So it means it's put an extra strain on the Uxbridge GPs. So how do you plan ahead? How do you work with planners and other services in getting GP services into the right areas? Because that's a large area with no GP surgery, and I don't know. It's just a question. If you could answer, how do you work? Do you work with planners? Do you have any contact with them?
So normally estates questions will get answered by commissioners, but I'm going to jump in on this one as a Friday, because one of the things I've been in Hillingdon now best part of 7 years running the Confederation, and one of the areas that has think of a language for a public meeting, but displeasured me, is the fact that our development of general practices has not followed an integrated plan particularly well. It's been a little bit, I wouldn't say ad hoc, I'd almost like point decisions, individual decisions being made to go ahead or not to go ahead around the particular circumstance at the particular time, particular finances, particular developers, etc., etc., without reference, I think, to a proper integrated plan. One of the things we've worked on really hard over the last few years is an integrated estates plan, joined up with and agreed with the council and with the ICB and with the providers. Quite frankly, the distribution generally, if you look at where the populations are in Hillingdon, with the exception, I absolutely accept, of the Western Heathrow villages, there are general practices largely where you'd expect them to be. But down in the detail, there are gaps, and there are some GP practices that cater for 4 times the number of patients than a similar practice elsewhere on the patch. So what we have done is agree a framework for a strategy in order that each decision made henceforth will be done with the reference of a strategic plan, so that we won't, I mean, if we were to take West Drayton and Newsley, where there's been high population growth because of the Elizabeth Line station and the investment in flats and the like down there, there hasn't been any general practice capacity built there for well over 30 years. And it's desperately in need of some change there.
Who decides?
So those sorts of things have got to
what's interesting is who decides, because GPs are independent entities, essentially. So if GPs are there, they sort of, they manage themselves in a sense they're self-employed, I suppose. So if there's a place where there's no GPs and suddenly we need GPs, well, it's not like the NHS says, oh, okay, we're going to put some GPs there. Do we have to wait for GPs to sort of migrate naturally and set up home there? Or, I mean, who decides that a GP surgery will set up somewhere?
Well, it isn't generally the GP themselves. It will be a commissioning decision around the needs, and there will be largely financial formulas that are exercised by the commissioners at an ICB level. I mean, Sean can speak more to that. I think one of the other dangers is that when a GP retires and they're the last partner in the practice, does the practice disappear, and does the list get dissipated, or does it get continued? And that's also a commissioning decision. And so that piece about, is a new practice required, is an existing does a practice that's under threat be sustained and new GPs be brought in, all of those will be referenced in future on the basis of the strategic plan. And it does, it will say that these practices, if the partnership dissolved, there is not the capacity locally, either through access or just general capacity, to allow this practice to go. It needs to be sustained. So there's almost like a post-it on the map saying these ones need to be sustained because there isn't the neighbouring facilities to accommodate these patients. those sorts of things are there in that strategic plan going forward. So it will be better planned than the way it has been.
So in theory, you'll say, okay, we need, let's say for example, West Drayton, we need some extra GP surgeries, we've got money for it, dear GPs, can you please apply to sort of start running it, or or take over? Is that how it sort of works then?
Yeah,
I
think the classic thing there, because the other thing that's got to be done is the freeing up of the actual value of the estates. Unfortunately, if you sell something in the NHS, that money can't be used currently for reinvestment. So the classic piece in West Drayton is there is public estate there, owned by NHS Property Services, for instance, that if that's sold, that couldn't be reinvested, and yet it's on prime land. So freeing up those sorts of decisions is absolutely fundamental. That's not even an ICB decision. That requires government to change rules on capital allocations and the like. So there's some of the big decisions, to be honest. Commissioners going back 10 years or more in Hillingdon have not had it in their gift. What we have had in our gift now is to put a strategy together to say what is needed and what should and shouldn't be allowed. We still need the capital rules being flexed in order to free things up. And again, I was talking literally with Tony Zayman just today on how we work better with the council, and have we got complementary things that we can bring to that equation. I think it's really important. The council has got far more estate in Hillingdon than the NHS, and working in a complementary way with the council will enable us to have far more opportunities. But there is a reference document now that allows us to make better decisions, but the money side of it still needs to be allowed.
Another question on another tack. How is the quality of service provided by each practice monitored, and what action is taken in response to concerns about quality and complaints?
So there are, the headline is that every practice is CQC accredited, they're inspected, they're rated, and where they're subject to improvement, there can be notices served that forces them to improve. So that's a baseline regulator activity. The CQC is very active in Hillingdon, even currently. So it is something that has teeth, and practices are very well aware of. I think what I've detailed in some of the contracting processes is that data from general practices is very visible and frankly quite immense. So the quality and outcomes framework is a national framework. The GP data feeds into their ES services that they're contracted for. There are about 188 measured points in that contract for general practice. So there's a lot of detail. In fact, general practice will feel like it's almost micromanaged, and you're forgetting almost like the patient-client relationship. There's a lot of measurement. But on the complaint side of it and incident side of it, general practices generally deal with, monitor, learn from their own complaints, their own incidents. They have their own internal governance arrangements as separate legal entities that are accountable to the partnership. I think in that regard, it's a little bit self-contained. And one of the things we're working on with our practices and our primary care networks is actually starting to try and share incidents. So we've got a reporting and incident system where we're trying to share and learn from incidents. but quite honestly, some of that work is quite self-contained within practices.
Okay, so we've got our last councillor, Councillor Nelson West, and then every single councillor would have asked questions, which is amazing. And because we've been here an hour and a half, I'm going to suggest that after Councillor Nelson West has asked a couple of questions, any further questions we submit through Nikki by writing, because otherwise we could be here all night. I promised people we'd be about an hour, and we're already an hour and a half, which shows you how much I know. So, Councillor Nelson West.
Thank you, Chair. What's the take of a pharmacy's commission to provide service to GPs, and is it actually alleviating any of the pressure on the GP services?
Could I ask you to repeat the start of that question? Sorry, I didn't pick up the start of the question. Apologies.
Yeah, what's the take-up rate of pharmacy's commission to provide service to the GPs, and is it actually alleviating some of the pressure off the GPs? Is it helping them in any way? You know, because services are going out.
So I won't say whether, I suppose, say is it alleviating some pressure from the GP. I suppose you can see some of the appointment availability or appointments are going up. What you're probably doing is just taking away some of the patients that would have gone there, so you're able to see the patients to a certain degree. I will reel off a few facts and figures just on the pharmacy data that I've managed to pull together, and I will explain it as best as I can as I go through. So, Pharmacy First, so you have something called Pharmacy First, which can provide 7 sort of key ailments or conditions and stuff that pharmacies can support. So, did you want to know what services they provide? Yeah? So you can do UTIs, impetigo, acute sore throats, shingles, infected insect bites, acute sinusitis, and I won't pronounce the technical term, but a middle ear infection. So I suppose it's the sort of stuff that's that little bit lower down that you potentially need some antibiotics for or seeing through. And out of our pharmacies, 58 out of 59 pharmacies have signed up and are delivering. They might not be delivering all 7 of those services, but they've signed up to deliver those services. So actually patients, residents can go into those pharmacies. They will do a consultation, and if medication is required, they can support you with that. The other services that the pharmacies offer is hypertension case finding service. So it's trying to look at patients with high blood pressure, take their blood pressure, monitoring if they haven't had it for a while. And actually 56 of the pharmacies have signed up to those, so out of 59 I believe it was. And then there is the pharmacy contraception service, which is providing access to contraception, including emergency contraception, and 53 of the pharmacies have signed up to provide those services. And alongside there you've got obviously your flu vaccine service, smoking cessation, and COVID vaccination, so various vaccination services. So quite a good uptake with a range of pharmacies that we've got within Borough of Hillingdon. I mean, I have some of the numbers.
Tell us the couple of most interesting, fascinating ones.
Well, actually, I mean, it's a good. So I suppose since January, so the data I had, that was from May, that all those pharmacies had signed up to it. From January to May, I suppose there is just shy of 4,000 minor illnesses that have been seen within pharmacies. So actually, that's quite good. If you didn't go there, if you didn't go to your practice, you'd be going to UTC. So being able to go into a pharmacy that's around the corner and local can support that. Urgent medical supplies, so probably the supply of the urgent medicines that they're reviewing. Just 5,500 of those, so again, quite a good uptake. Quite a lot of the blood pressure monitoring has taken place. So since January, about 12,000 blood pressure monitoring has taken place. So actually, and that's one of the key drivers to support with hypertension. And it's a lot of the work that the neighbourhood teams have been doing. So if we go back to the neighbour teams, and they're linked into pharmacies and working at practices like that. So that's a good sign, because that's what we've been trying to work through, one of the key things. So hopefully that's answered your question.
Yes, thank you. Every time I go into my pharmacy now, they want to take my blood pressure. Is it the way I look when I walk in? I don't know. Got a quick follow-up or not? Yeah. What other additional services have been explored to alleviate the pressure? Any other, besides what you said, any new ones you're exploring or thinking about, trying to take more pressure off? Any more serious things that they can do, that the doctor would normally do, maybe?
I'm not as close to the next development. Obviously, we've got a whole management team that work a lot closer with this, and I mean, these are the ones that have supplied me with this information. Is that a fact? Okay.
Just a couple of things that we know about that I've been working with some of the integrated neighbourhood teams with is we actually now have a children and young people champion role within one of the PCNs to try and alleviate the impact on GPs with regards to referrals for mental health support for children and young people, and that person is there to help families navigate the system as well and get them to the right service that they need for their child. So that's one of the kind of new services that's been put in place for a year initially, just to kind of evaluate how well that's working. But the plan is that will, when we know that is a big issue for GPs. So that's been put in place to try and support GPs to manage that. Some of the other things that we know about, we've talked about the additional roles, and I think there are plans, aren't there, to introduce more additional roles within PCNs. I don't know if you're aware of that, but yeah, there are plans to introduce some more additional roles, so practice nurses within some of the PCNs as well. So I think as from what I understand and working with the teams, is that as they're sort of analysing what the neighbourhood population needs are, they're looking at how services can be tailored to try and meet those needs, and then utilise that team within the GP practice to make sure people sort of get to the right practitioner to accommodate their needs. So that's just, but I think that the children and young people's role is really fantastic, and and in fact I was involved in the interview process for that person. So I'm really looking forward to seeing how well that works, and hopefully hearing some really good feedback from families in terms of trying to reduce the reliance on CAMHS and these sort of long waiting times to get into children and adolescents mental health support, but actually utilising other services within the voluntary sector as well that often are a bit more suitable to that child. So yeah, that's just one example.
That's me. Have they started yet, this person?
I'm not sure what their start date is, but they've been recruited, and they should be due to start, I would think, in the next few weeks if they haven't already.
Unfortunately for them, I'd like to invite them to the committee in about 6 months' time to talk about their experiences and what they've learned, because we did a big report on children and mental health and access to it, and one of the big issues was actually being able to access things as quickly as possible and the confusion about what's available. So that sounds really, really good, and I think we're really interested to find out what's happened. So maybe in sort of 6 months' time, I'm looking at Nikki, who sort of runs our work programme, it'd be really good to get this person to come and talk about their experiences and what they learnt, because you're right, I mean, it would, hopefully this would allow families to be able to access services as quickly as possible in an area where the quicker the better, but also alleviate pressure from GPs having to deal with stuff which is, time consuming and all that sort of stuff. So that sounds really good. Okay, so I'm going to guillotine this now because we've been here for an hour and a half. I've got one request. Are we able to share this report now, Lisa, with the rest of the committee?
Yes. Please
Cool.
do.
Okay.
It's signed off by the board, so
Great stuff.
I will be publishing it on our website at some point this week.
Great stuff. So Nikki's already got it, so can you share it with the rest of the committee? For the committee, everyone's asked questions tonight, which is brilliant. It's like a full house of bingo. Top quality, single review, performance committee. But any further questions that anybody might have that they want the panel or others to answer, please let Nikki know by next week, I think, just to give us time to ask the questions, answer and feed it in. That would be very useful. Lisa.
Just before we finish, as you all know, I'm leaving Healthwatch, and I actually left at the last meeting, but I've been brought back for this special one. Can I introduce you to Colleen, who is from Your Voice in Health and Social Care, who will be taking forward the Health Watch service from the 1st of August. So Carleen will be your point of contact for any future meetings.
Fantastic. We look forward to you participating in future meetings. And Lisa, goodbye again and well done and fantastic, and it's really great having you. And it's not unusual in the NHS for people to come back again in different forms and different reincarnations, so it may or may not happen, who knows.
Or the local authority, might I add, as well.
That is true. There is a linked path in there as well, so best of luck for the future, and we've obviously really appreciated the effort and the work you've done for us. It helps us do our job better. Also as well, I'd like to say, just any ideas in terms of recommendations, me and Nikki will talk about them and send them over email, but any ideas people have as well, because ideally we'd like to get this all done so we can have it ready for the September meeting. If it slips to October, that's fine. That's it. Okay, so I'm just going to finish this item now. Thank you so much for being here for an hour and a half. You're all free to leave now, but we really appreciated it. Thank you. Okay, so we're on to, yes, Cabinet Forward Plan. Does anybody have any comments on the Cabinet Forward Plan? No? Brilliant, fantastic. Then we come to our final agenda item, the work programme. I have one suggestion, I think. I don't know if I have more. But what I was looking at, in terms of April's committee meeting on the 21st of April, that's super close to the local elections. And so for a number of reasons, I think in terms of us being distracted and potentially what witnesses may or may not feel comfortable talking about, I propose that the 3 items under health external scrutiny, so the health updates and Hillingdon Hospital redevelopment plan, gets shifted into March's meeting. Are we happy with that? It makes sense. It makes sense for us, doesn't it? Because on the 21st of April we're going to be like, our mind's going to be elsewhere, and also, you know, well, yeah. Maybe it's not on the beach, some of us. Some of us on the streets of Uxbridge, and the rest of us on the beach, probably. Okay, good. I think that's everything. Is there anything else on the work plan?
Chair, having just mentioned about children and young people's mental health coming back to a future meeting, so we're currently in July, so that would make it about January, February time. So on the work programme, we have actually got a future update on the CAMS referral pathway review that was undertaken by the committee. So I wonder whether we ought to try and put the two together and maybe have them in January or February.
That sounds great, yeah. Well, that makes sense together.
Okay.
We're all agreed and happy with that. That makes sense. Brilliant. Is that everything? Okay, well, I'll call this meeting to a close. Thanks, everyone. It's been interesting.